So today we are going to discuss about breast carcinoma, a clinical case discussion. Okay, so this is a very important long case in practical examinations and it is very important. So let's discuss this. So in this first slide you can see the picture of breast carcinoma. On the patient's left breast you can see a fungating growth. You can easily appreciate it. This is an example of breast carcinoma. Okay, now let's take the history. So how we will take the history? We will suppose that a 45-year-old lady who is a resident of Haryana, illiterate, of low socioeconomic status and is a homemaker. And we suppose that she comes to OP with a lump in her right breast since 6 months. Okay, then you have to describe the lump. That what is the onset? So we will say it was insidious in onset. Then initially it was 2 into 2 centimeters and later progressed to 7 into 8 centimeters. So you have to tell that lump means you have to tell the onset and its progression, that how it progressed to the current size. Okay, and then you have to tell whether it is associated with pain or not. So earlier it was painless, but since last 2 months the patient is complaining of a dull aching continuous pain and that pain relieved by medication. So you have to mention the relieving factor for that pain. So in this way we'll write history and we'll write the chief complaints. Okay, chief complaint should be written in patient's own words and in chronological order. So we have mentioned about the lump, its onset, its progression, whether it is associated with pain or not, and how it is relieved. So we have mentioned that it relieved by medication. So next, in the next slide, we'll write about past history. So past history, we will write history of ulceration 2 months back, which was associated with foul smelling discharge. So she is having pain in that ulceration 2 months back and foul smelling discharge is there. And ulcer progressively increased to current size of 7 into 8 centimeters. That means the ulcer is increasing in size. And then we'll mention whether any discharge from the nipple, any history of retraction of nipple, because sometimes congenital retraction of nipple is present. So we have to check that. Then no history of loss of weight, because loss of weight will be there in malignancy. So any history of loss of weight, any bowel or bladder disturbance, and intake of oral contraceptive pills, because oral contraceptive pills also increase the risk for breast carcinoma. Diabetes, hypertension, asthma, epilepsy, any addictions. So we have to take the complete past history. So first we have written ulceration, we have described and how it is increased to the current size, any discharge, any retraction, bowel, bladder, all the diabetes, hypertension, asthma, epilepsy, addictions. And we also have to mention about any medications if the person is using any kind of medication. So we have to mention that. Okay, next, this is menstrual history. So since it's a case of breast cancer and that too female breast cancer, so we have to take the menstrual history. It is very important. So we'll ask when she attained menopause. So she attained menopause 5 years ago. Okay, means she is currently 45 years. So she attained menopause 40 years. That is normal. And asking menopause age is very important, because if the lady attains menopause very late in her life, so there are more years of estrogen exposure. So more chances of breast cancer. So we have to ask when she attained menopause. Okay. Then menarche at 12 years, same for menarche. If she attains menarche at a very early age, more years of estrogen exposure. Again, more chances of breast cancer. Then P3, L3. Okay, she is having 3 live children and she breastfed all children, because breastfeeding decreases the risk of breast cancer. So 1 year of breastfeeding is very important to reduce breast cancer chances. Then last childbirth was 20 years ago. Okay, done. Then comes the family history. So we have to ask any history of breast cancer, ovarian cancer, colorectal malignancies in the first degree relatives, because if any cancer in first degree relatives, the chances of cancer in the patient will increase simultaneously. Okay, so next comes the examination. So first is general examination. So we'll mention, okay, she's moderately built, she's moderately nourished, she's conscious, she's cooperative, well oriented to time, space and person, and she's occupying a decubitus of her choice. That means she's comfortably sitting or lying in whatever position of her choice in which she is comfortable. Then you have to check her hydration. Okay, normal hydration. Then you have to mention all the vitals, you have to check them. Pulse, blood pressure, respiratory rate and temperature. Then you have to check for any pallor, icterus, edema, cyanosis, clubbing, lymphadenopathy. Okay, right axillary lymph node palpable. You have to palpate the lymph nodes. So, right axillary lymph nodes are palpable. You have to mention, okay, the axillary lymph nodes. Next comes the local examination. So always you have to first check the normal side, then you have to go for the lesion side. So first we will check the left breast. Okay, left breast and axillary region, no abnormality detected. And examination, always examine the patient in both sitting and lying down position. Okay, left breast done. no abnormality detected. Then we'll go to the right breast. Nipple areola complex is at a slightly higher level than left, and you can appreciate it better when you ask the patient to raise her both arms up. So then you can easily appreciate if the nipple areola complex is at a slightly higher level or not. Okay, you can easily appreciate that. Okay, then you have to mention about any prominent veins that you are seeing on the chest wall or on the breast of that patient, and then you have to mention where you are seeing the ulcer. So ulceroproliferative growth is seen on the upper outer quadrant, and it is of size 7 into 8 centimeters. Upper outer quadrant means cancer chances are more on the upper outer quadrant. That is very common. Okay, then you have to describe the ulcer. We'll describe the margin. What is a margin? You can say it is the contact between the lesion and the normal side. That is margin. Means we have a particular ulcer. On the adjacent to it, you'll have the normal cells. So that contact is called the margin. So irregular margin, everted edges. Edges means suppose you're in a room. So the wall that you are seeing, these are the edges. So they are everted. And on the floor, you can see slough on the floor with pale granulation tissue. So we have described the ulcer. We'll describe the discharge also. Foul serosanguinous discharge and bleeding on touch. Skin is indurated. And nipple, it is not retracted. Okay. And no discharge from the nipple. Okay, done. Then ulcer is firm and mobile. So now you have to check the mobility of that ulcer. So you will ask the patient, you ask the lady to bend slightly forward, and then you try to move that ulcer in 2 axes. Okay, first up and down, then left and right. You move that ulcer. If it is moving, okay, we'll say that this ulcer is firm and mobile, and it is moving in 2 axes. Okay, but the muscle is not taut. Now what you tell the patient? You tell the patient to bend forward and now put her hands on her waist. In this way, the pectoralis muscle will get taut. Now again try to move that ulcer in 2 axes. If it is moving, we will say okay, the ulcer is firm and mobile. Now we will check the axilla. Because breast, lymphatic drainage of breast, axillary lymph nodes are very important, so you have to check the axilla. Okay, so we are seeing enlarged central group of lymph nodes. And how you will check for the axillary lymph nodes? You will, the examiner's right hand, suppose if I am the examiner and my patient is sitting in front of me, I will place my right hand over her right shoulder, and then I will palpate her axilla with my left hand. Okay, I will check for any palpable lymph nodes, and you can ask the patient to place her hand over my elbow for support. Okay. So in this way means if I am the examiner, my patient is in front of me, I will place my right hand over her right shoulder, I will palpate her axillary lymph nodes with my left hand, and I will ask her to place her elbow on my hand for support. Okay, so I can show you this in the picture. That picture is not that clear, but you can appreciate that the examiner is palpating the lymph nodes and the patient has kept her hand over the examiner's hand for support. In the second picture, you can easily appreciate it. In the first picture, what you are seeing is the examiner is standing behind the patient and she is palpating his superficial, cervical and supraclavicular lymph nodes. First, you will examine the axillary lymph nodes. All axillary lymph nodes you will examine, and then you will examine the supraclavicular area also for lymph node. You will stand behind the patient for supraclavicular lymph nodes, as you have seen in this picture. For axillary lymph nodes, I have already told you the position. So here, axilla is palpated with the pulp of fingers. Okay, with the pulp of fingers, you have to palpate the lymph nodes. Anterior, central, apical and lateral lymph nodes all are felt. And the patient is asked to keep her hand over the opposite shoulder. Okay, and the posterior group of axillary lymph node is felt by examiner from behind. Okay, you will from behind only. It is on back side, no? That posterior is slightly on the back side. So you have to check for the posterior axillary lymph nodes. Means anterior, central, apical and lateral all are anterior only, but posterior group of lymph nodes will be felt from behind. Okay, so done. Okay, we'll say that 3 in number, means 3 palpable lymph nodes are there, and then you will tell the size. Okay, they appear to be 2 into 2 centimeters and they are mobile, and then you have already examined the supraclavicular fossa and the neck lymph nodes. How you have checked that? By standing behind the patient. I have shown you the picture now in that slide. Okay, done. This is all about local examination. Then next comes the systemic examination. So respiratory, cardiovascular, central nervous, perabdominal, any spine or external genitalia, rectal and vaginal examination, all are normal for that patient. Okay, next comes the diagnosis, the provisional diagnosis. So we will write a 45 years post-menopausal lady with fungating growth in the right breast Okay, suggestive of locally advanced breast carcinoma, CT4B and MX. Okay, this is actually how you have to write the cancer. You will study this in theory only. C is clinically. Okay, you are checking that clinically, no? Okay, so clinically, T4B because there is skin involvement, so you will write T4B. Then N is for because lymph nodes are palpable, so N means okay, palpable lymph nodes. And MX means metastasis, not because how you will check metastasis clinically, no? You cannot. So MX means you metastasis. So C is for clinically. Okay, clinically you have examined and you have found that cancer is for T4B because there is skin involvement. Because skin involvement means that is anterior chest wall involvement is there, no? That is T4B. You will read this in theory. Okay, then you have to write okay N. Why N? Because lymph nodes are palpable. And MX, that is metastasis cannot be assessed. Okay, so you will write okay, this is the breast carcinoma, this is a staging. Okay, done. Then it is not a phyllodes tumor. Why? As they do not fungate and do not involve axillary lymph nodes. We have to tell okay why it is not a phyllodes tumor. Tell me. Because phyllodes tumor never fungate, and here you have found a fungating growth, and you have also seen the palpable axillary lymph nodes, and phyllodes tumor never involve the axillary lymph nodes. So enough for this. But okay, what are the investigations you will do for the patient? You will go for biopsy, incisional biopsy, PET, CT. For staging, blood examination, you will go for X-rays. And how you are going to manage? By neoadjuvant chemotherapy. Neoadjuvant chemotherapy, what does that mean? That means you will by chemo means you will shrink the tumor first. Okay, by giving adjuvant chemotherapy, what you will do is you will shrink the tumor and then you will go for surgery. Whenever there is locally advanced breast carcinoma, you give neoadjuvant chemotherapy to shrink the tumor, then you will go for surgery. Modified radical mastectomy. Always after modified radical mastectomy, you have to go for radiotherapy to prevent the recurrence. Okay, you have gone for radiotherapy, and if the tumor is ER/PR positive, that means estrogen receptor and progesterone receptor positive. You will read this in theory. If any breast carcinoma is ER/PR positive, no, you have to give her hormonal therapy as well. Okay, so in this picture you can see modified radical mastectomy. This is how surgery is performed. You have given an incision, and you have also then you will remove the carcinoma, and you will also remove the associated lymph nodes. Okay, so this is all about the clinical case discussion of breast carcinoma.